Good afternoon, everyone, and welcome to today's webinar entitled From Conception to Birth, the Evolution of Uterine Transplantation. We're glad that all of you could join us as we have an exciting presentation in store for you today. My name is Deanna Fenton, and I am the Program Coordinator with the Alliance. We have just a few logistical items to review before we begin today's program. For those of you who have never joined us on this webinar platform before, the chat feature is located in the bottom left-hand corner. We are recording this webinar, so we will not be opening the phone lines. That means that all questions must be submitted electronically using the chat feature. If you have any questions that come up during the webinar, feel free to submit them at any time. Once the presentation is complete, we'll have some time for our presenters to address as many of your questions as time allows. Registration is currently open for our next webinar, Palliative Providers, Perfect Partners. That's coming your way on August 18th at 2 p.m. Eastern. Registration is also open for our upcoming webinar, Compassion Fatigue, Building Resiliency and Treating Burnout. So be sure to join us for that on August 28th at 3 p.m. Eastern. You can register for all these webinars and more on our website at organdonationalliance.org. For today's webinar, we are offering 1 Step-C credit and 1 nursing contact hour courtesy of Iowa Donor Network. Everyone listening to today's webinar is entitled to claim continuing education credits. If you are listening in a group, as many of you are, please make sure to get the evaluation email from your group lead. It's a very brief online evaluation which will allow you to receive your credit. As a reminder, for nursing you have 14 days to claim your credits, and for Step-C you have 30 calendar days. At this point, I'd like to introduce our moderator, Haiti Aguiar, the Senior Director of Programs here at the Alliance. Haiti, we're so glad to have you with us today, and at this point, I'll turn it over to you to introduce our speakers.
Thank you, Deanna, and welcome everyone to today's webinar. I am really thrilled and humbled to have the opportunity to introduce our 2 fabulous speakers for today. Dr. Liza Johannesson was able to join this presentation and brings a tremendous amount of expertise as well to this presentation, so we're really excited that she was able to join as a speaker for today as well. I will start with introducing Dr. Giuliano Testa. Dr. Giuliano Testa, recently named by the Time as one of 2018's 100 most influential people, came to the U.S. after obtaining his medical degree cum laude and completing his residency in general surgery at the University of Padova Medical School in Italy. He completed his fellowship in abdominal organ transplantation at Baylor University Medical Center in Dallas and was instrumental in starting an adult-to-adult living donor liver transplant program in Germany. And that was the first in Germany, or the first in Europe, and ultimately was recruited to lead the living donor liver program at Baylor, where he is now the chief of the abdominal transplant program for the Simmons Transplant Institute. Dr. Testa also has previous experiences as a surgical director of the living donor liver transplant program at the University of Illinois and also director of liver transplant and hepatobiliary surgery at the University of Chicago. Dr. Testa has an MBA and a special interest and associate directorship experience in ethics and is actively involved with the American Society of Transplant Surgeons and UNOS, serving on living donor and ethics committees. Dr. Testa has authored and co-authored more than 160 manuscripts and several book chapters, and he is recognized authority in the field of living donor liver transplantation and living donor intestinal transplantation with a new interest in uterus transplantation. Now, Dr. Liza Johannesson specializes in obstetrics and gynecology with a special interest in gynecologic oncology and transplantation. She graduated from the Nobel Prize awarding Karolinska Institute in Stockholm, Sweden, and her residency in obstetrics and gynecology was completed at the Sahlgrenska University Hospital in Gothenburg in Sweden, and followed by a fellowship in gynecologic oncology at Sahlgrenska University Hospital and also at the Royal Adelaide Hospital in Adelaide, Australia. She started doing research in 2009 on uterus transplantation and presented her PhD titled Uterus Transplantation and Experimental Study in Primates in 2012. She was a part of the pioneering first clinical human trial of uterus transplantation that started in Sweden in 2012 and so far has resulted in 8 live births. In 2016, she started working with Baylor University Medical Center in Dallas to form the multidisciplinary team needed for the start of a clinical uterus transplantation trial. Since March of 2017, she is employed by Baylor University Medical Center as a clinician, investigator, and assistant professor to continue the research and clinical work with uterus transplantation. She is the only doctor to be involved in both the first and the second center in the world to have successful and live birth after uterus transplantation. She is the author of numerous peer-reviewed articles and lectures extensively at international scientific conferences, and she's a mother of 3 daughters and married. So you can see we have an extreme amount of expertise here on our call today, and I'm absolutely delighted and excited to hear what they have to teach us today. So I'll turn it over to Dr. Testa and Dr. Johannesson to take us through their webinar.
So I guess that's where we start. Good day, everybody. This is Giuliano Testa. Thank you for the introduction, Heidi. Really appreciate it. And our task today is to introduce the audience to uterus transplantation, and for the ones who already have heard about it, try to give as much information as possible. And we welcome questions, comments, or anything that may help us making this a mainstream treatment for absolute uterine infertility. The beginning of the talk is mainly a talk based on the reasons why we embarked in uterus transplant. And so I will invite my partner, Liza, to really outline the reasons why, and since she's actually, as well said by Heidi, the only one who has been experienced physician in both successful birth in the world, I think she's the most entitled actually to start this. Liza, would you mind?
Sure. So a uterus transplant is a form of VCA transplant. It's a vascular composite allograft transplant, differing a little bit from the solid organ transplant. And the only purpose with the uterus transplant is to treat a certain kind of infertility. And that's the infertility that's caused by an anatomical or functional lack of the uterus. The aim is, of course, the birth of a healthy child, and that's, might I say, it's the only aim out there. And if you're a candidate of uterus transplantation, you either belong to the group on the left-hand side where you have no uterus. You can either be born without a uterus, that happens to about 1 in 4 to 5,000 women born, or you can have undergone a previous hysterectomy, and that could be due to previous cancers, myomas that you can't correct in another way, or obstetrical bleeding. Or you can belong to the group on the right-hand side, which has a relative cause of uterine factor infertility and having a non-functioning uterus. It can be due to adhesions, it could be to different malformations, or smaller leiomyomas that you can possibly remove surgically. If you look at the alternatives with these females, it's either to accept that they cannot have children, to live a child-free or childless life, depending on how you look at it, or to achieve motherhood, they can go through adoption, which is accepted in most societies around the world, or there's also an option for gestational surrogacy. That's legal in most of the states in the US, but where I come from in Europe, where Giuliano Testa also comes from, it's unlegal in most countries. The potential candidates, and how big is this group of women? Well, no one really knows. But we've looked into it, and the estimate is that you would have about in between 1 to 5% of women with this type of infertility. And if you look at the group in the US between the ages of 18 and 44, you will end up with a number of 600,000 to about 3 million females in the age group of 18 to 44, which you normally consider the fertile age. And not all of these women will be actual candidates for uterus transplant. Some of them won't even want to, some of them can't afford it, and some are medically unsuitable to go through. But even if you look at 1% of that group, you end up with a patient group of 6,000 to 30,000 patients in the US alone. So it's a large group of women, especially when you compare it with other organ transplants. So this is a slide from 2015 where you look at the kidney transplants done in the US. It's 18,000, and the pancreas is down to a couple of hundred, kidney pancreas a couple of hundred too. So if you look at our group of uterus transplants where you have in between 6,000 and 28,000 potential patients of the 1% of the entire group, you are up there with the kidney transplanted patients. So it's a large group of women. Uterus transplant is special in many ways. First of all, it's a non-life-saving transplant. It's not like the liver, who is life-saving, or as a kidney, who is life-enhancing and sometimes life-saving. It's also a temporary transplant. It's the first temporary transplant out there, meaning that we will have the uterus for a short period of time in between the transplant and the pregnancy and the delivery, and it's meant then to be taken out after the delivery of the first or the second child. There's a living or deceased donor option, and it's also, for the living donors, it's kind of unique because the organ has actually exhausted its function in the donor when you take it out. It's not like a kidney or a part of a liver that you can potentially need further on in life. The uterus, when you're done with your childbearing, you're done with the uterus. And it doesn't affect your hormonal activity because we do leave the ovaries in the donors. There's also several parties involved. There's the donor, the recipient, but there's also the partner of the recipient, the future co-parent, and of course the future child who is involved in this. And what's also special about it is that it's a stepwise success. So you have the surgical success first. The week after surgery, you see that the organ is vital and it's staying within the recipient, but also then the first functional test after you have the first normal menstrual bleeding. Then you have a period of time where you have to find that stable immunosuppression, the patient needs recovery from surgery, and then the second functional test comes where you have to implant an embryo, and you have to look at a successful embryo implant to last for entire pregnancy, which is the third functional step. And eventually, down the line, you come to the delivery of the child, which is actually the only measure of success in a uterus transplant. So it's a long journey for everyone involved. So briefly, just about the history of uterus transplant. It started already in the 30s, in 1930. There were a couple of cases done in the early 2000s, along with a couple of animal transplant animal models. And then the first trial was in 2012. And then further on in 2014, 2015, the first transplants were being done in the US. So I'll briefly go through the history. This is the first case that was actually described. That was in Germany in 1931. It was actually a movie done about this case called The Danish Girl that some of you might have seen. The movie is about a transgender female that goes through a lot of different surgeries, and the last one of those was actually a uterus transplant. Unfortunately, this was before the immunosuppression and everything, and the patient died a couple of months after the transplant. You can see the cost approximate down there is £12,000. So this was an expensive surgery already back in the 30s. The first clinical trial that was done in Sweden, and that was a trial that I was a part of. We started in 2012, and we had only living donor uterus transplantations. We had 9 recipients, and most of those patients were Rokitansky patients, meaning that they were born without the uterus. We also had one patient that lost her uterus in her teenager due to cervical cancer, and that later, 7 years after that, received a uterus transplant. This is the publication we had after the first birth in 2014. On the upper picture, named A, you can see the uterus at transplant. This uterus came from a living donor that was a family friend of the recipient. She was 61 at the time of transplant, and when the child was born, this uterus was 62 years old. And here you can see on the lower picture, you can see the uterus when it's within the recipient. So the first successful birth we had and the first successful uterus transplant in the world was in September 2014. That was when this boy was born. As I said, the donor was a 61-year-old family friend, and the recipient got pregnant from her first embryo transfer. She developed preeclampsia in week 31, so we did a premature delivery with a C-section. In saying that, though, the boy is now almost 4 years old in September, and he's doing great. The APGAR was 9, 10, 10, and he weighed 1775 grams, which was appropriate for his gestational age. So the outcome from the first Swedish trial, you can see all the 9 patients here, and the happy smiles are the babies that's born. So you can see that there is 2 graft failures, number 2 and number 9. One was due to surgical complication and thrombosis, and the other one was due to a intrauterine infection. The remaining females, except 1, has delivered babies. So 6 females have delivered babies, and it's in total 8 babies delivered. The last female that hasn't delivered has had a lot of pregnancies that unfortunately has ended in miscarriages, and she still has her uterus. So this is just a graph showing you how many babies there are born in the world so far. So we have 8 babies, as I said, in Sweden. We have 2 babies here in Dallas, and there is 1 baby born in Brazil, and there's also 1 baby born in Serbia. After a transplant that was done in Serbia, the baby was born in Italy, but that was in between 2 identical twins, so that was a uterus transplant without immunosuppression. So the first American case that was done was in 2016, and that was Cleveland Clinic, and the team was led then by Andy Tsakis on your right-hand side here. They used a deceased donor and a recipient that you can see in the middle of the picture that was 26-year-old and born without a uterus. Unfortunately, they had complications, so they had to remove the uterus 10 days after the transplant, and that slowed the Cleveland team down a bit, but they have now started doing more transplants. They are only doing deceased donor transplants so far. Do you want to take over, Giuliano?
Yeah. So what happens here was that we became aware of uterus transplantation, and we brought that idea to the institution. The institution was interested in starting a program of such. We went through all the necessary steps through the ethical commission, the medical board, the institutional review board, and finally we were able to start a program based mainly on all physicians that already worked at Baylor, aside Liza, who joined us from outside our institution. The number one hurdle was to make sure that people knew that we had a program like this in our hospital, and we didn't know any better than going on to the newspaper and tell everybody we were starting this program. It was quite intriguing because we hadn't done any transplant as such, but we had a significant number of requests, up to close to 200 women called and were interested in the program, and up to, we have actually this, Liza is telling me that I have these numbers, and we had also an incredible response also from women who already had kids and were willing to donate their uterus to allow other women who could not have kids to have the same procedure. And it was very, very intriguing to us to see this incredible response, to the point that Liza, together with our group, look into the motivations and the number of women who stepped forward for this novel procedure. And that was interesting also because we got really immediate response to our hypothesis that the number of women who might be interested in having a transplant because affected by absolute uterine infertility is fairly large. And so if we were able to bring this to mainstream therapy, we'll have many, many women who could benefit from it. So that was a very important step. From this pool, we selected 10 recipients. Of course, we tried to super select them. We try to make sure that the women were as fit as possible, not only physically but also mentally, to go through the process. And we had also super selected the living donor from this, but we were at that time also the only program that was offering both living donors and diseased uterus transplant to our candidates. So of the entire number of transplants that were performed, at the end of the day, we ended up doing 8 living donors and 2 deceased donors in our series. The first step was to do the surgeries, and we opted for at that time inviting Dr. Johannesson, who was not still with us yet, and Dr. Michael Olofsson, who is the chief of transplant in Gothenburg, and who was the one who was involved in the surgeries in Sweden as well, to help us out. So we did 4 surgeries, one after another, and the beginning was rocky. The beginning was unfortunately plagued by 3 failures that came one after another, and shook us a bit, but then we were blessed with the 4th transplant that was successful. And that gave us the strength to, not only us as surgeons and physicians, but also the institution to support us in continuing with the trial. And we will never really forget and always mention the women that underwent this procedure and were not able to fulfill the desire to have a pregnancy because the uterus transplant failed. The donation is a pretty meticulous retrieval surgery, procurement surgery. The idea is to have the entire uterus out, including the vessels that feed the uterus. And for the purpose of the surgery, we need the 2 arteries. They are called the uterine arteries, and they are procured together with a segment of a larger artery to make the connection between the transplant and the recipient a little easier. And then we have between 2 and 4 veins. The veins are the ones that are supposed to bring back the blood from the uterus into the mainstream circulation. And those are based on the uterine vein. That's a very elusive vein. It's there sometimes, it's not there sometimes. It's been really not easy to have a standard retrieval of this vein. And then the uterovarian segment of the ovarian vein is the other vein. So we have 2 veins in each side and 1 artery in each side that constitute the transplant. At least 1 artery, at least 1 vein per side needs to be connected. This is a blow up of the arterial segment that you see during the dissection, and the ureter, which carries the urine, is the one that is underlined by the yellow color, and for some reason is made so that it travels between the uterus and the vasculature, so it becomes fairly cumbersome to be able to obtain the vessels without injuring the ureter. But it can be done, and thank God thus far we have not had any issues with that. Once the uterus has been procured, is placed on a sterile solution and is flushed, because it needs to be flushed of the blood that is inside it. And then, of course, it blanches completely and is kept in this special solution when it's prepared. The preparation mainly is make sure that the vessels are open, that they are intact, they can be connected, and also that there is no major point of bleeding in the moment that it will be perfuse the uterus in the recipient body. And the specimen you see here in this fluid is made by the uterus, a complete uterus, and then the cervix is the right side of it, and that's what the portion that will be reattached to the bolt of the vagina in the recipient. This is the same specimen on a blue towel, so outside the fluid, so it can be seen, and the 2 forceps on the right side held open the vein, which is the one through which the blood goes back from the uterus into the mainstream, and on top of it you can see a segment of the artery, which is one supposed to bring the blood to the uterus. That's another vision of the same part. The transplant itself is what we describe to our patient as a glorified plumbing technique, by which the vessels needs to be connected to the iliac vessels in the recipient. So the technique is not much different than the one is used in a kidney transplant. In a kidney transplant, the kidney is placed in a heterototic position, meaning that doesn't belong to the area, but the vessels are such that it makes the connection easier on the iliac artery and vein. In this picture on the left side, the segment on top is the artery, and the one which is in the clamp and pulled forward by the blue tape is the vein. And then, of course, the connection are performed. This is the other phase of the surgery. This is the vein anastomosis that's being completed, and then the one on the bottom part shows where the vaginal anastomosis will be completed. And that's the uterus at the end of the surgery. There are several pictures that show it. It needs to be anchored so it doesn't flip back or forth. And in doing this, nothing bad would happen, but it might happen that it twists. In doing this, it will twist the vessels and create a problem with the blood flow through it. And this is different part. This is the vaginal cuff, the vessels, arterial vessels on the back with the veins, and then this is what is being described. As I said, we had 10 uterine transplant, both from living donor and deceased. Those are simple numbers in terms of mean age of the donor, mean age of the recipient, and mean age of the time in surgery. And this is the first set of problem we found in the first three. Mainly what we describe in our terminology, vascular problem, meaning that if for one reason or another we had a poor flow to the graft or poor flow out of the graft, and that create demise of the graft. How do we find out? That what was interesting and was a learning curve is that this woman, despite having had a transplant that was not successful, were not showing any signs of having a non-functioning and non-viable uterus, which is completely different of any transplant that we do, by which if you do a kidney transplant that doesn't work, you don't have urine. If you have a liver that doesn't work, you have the patient really sick and very yellow. In this case, we didn't know, we couldn't find out through any other system that the uterus was not viable. So it took biopsies and then also an MRI to find out that there was no really viable tissue. And the biopsy, this is just, of course, not for people who have not familiar with the biopsy of a uterus, but bottom line is a uterus will show cells throughout the pink portion of it, and should show the margin, the top portion of the picture should be linear with a palisade of cells and not this disarray and totally disorganized picture of cells that shows there is suffering within the uterus. And this is another thing that we found the hard way. This is part of the learning process. We were coming with the experience from Sweden whereby some of the donors were not young anymore. So if, as you heard Dr. Johannesson, she said that the first recipient ever to have a successful birth had a uterus from, I believe it was a mom or
it was a friend of the family, and she was 61 years old at donation.
So that uterus was 62 when the baby was born, and it worked perfectly. In our oldest uterine transplantation, we had a donor who was much younger than 62, but presented, and we found out only after, unfortunately, uterus didn't work, with a severe arterial picture similar to what you have in atherosclerosis and when you have an MI, for example. So the artery is plugged, is not conducing the blood, carrying the blood in a smooth and easy way. And that is what it shows in this picture, whereby all the black arrows show a lumen, so an opening in the artery that is supposed to be completely white in this specific case, but in reality it's pink because it's filled with material that doesn't belong to it. And that was a problem that we encountered. And this was a dramatic imaging that Liza and I always show. It shows the uterus on top is the one of the unfortunate women who did not have a successful transplantation, and is completely black, and there is no viable cells in it. The one on the bottom is the fourth one that was successful, as you can see, had a very good perfusion to it. And then we had, of course, the functioning graft, which is showed here in an ultrasound. The blue and red dots within the parenchyma show to you that there is a perfect flow within the corpus of the uterus, the myometrium. And so that's really something that we always want to see in all these cases, and this is the waveform that we look for to assure that we have a good arterial flow within the uterus. And as you can see now, you see the biopsy on the right is the one I was mentioning before with a normal palisade of cells. There is no disarray. There is perfect black dots everywhere that represents the nuclei of the cells. So this is really a successful uterus. Liza, you want to go on and explain how we went on from this?
So the first birth we had here at Baylor was, as you can see, we transplanted her in September 2016, and that was actually the fourth transplant we did, so that was the first successful one, and the reason why we continued, basically. So we transplanted her. She was the donor was a 34-year-old female who had 2 pregnancies of her own and 2 children of her own, and she felt that she was done with her family formation. So she wanted to donate, and she was a non-directed donor. She didn't know the recipient. The recipient was a 28-year-old Rokitansky patient born without the uterus, and we had retrieved embryos prior to the transplant, so she had 5 good quality blastocysts in the freezer. She had her first menstruation starting 6 weeks after her transplant. She was terrified at that time. We were terrified. She was bleeding, but then we found out it was just menstruation, so we were happy again. So, and we decided to go on with the embryo transfer for her in April 2017, so about 7 months after her transplant. We were very lucky. The embryo that you can see there on the picture responded well to the uterus and started to grow within the uterus, so she became pregnant, and we found out in May. So she had a fairly normal pregnancy. We decided anyhow to deliver her a little bit earlier, and that was due to the fact that she had an impact on her kidney function. The immunosuppression had an impact. So she had a decreased function at that time with a low GFR and a high creatinine. So we decided to deliver her when she was in 34 weeks. And the baby was born. He weighed about 2 kilos, and the Apgar was 8-9, and he was normal length. So everything went really, really well. And the special thing with this delivery was 2 things. First of all, in this first Swedish study we did, we waited a year after the transplant to give the embryo back. And that was based on regulations from way back when the transplant recipients were very sick, and you wanted them to wait a year after the transplant before you even considered having them pregnant. We didn't think that these healthy uterus transplanted patients needed that long of a wait, so we went sooner, and that worked out really, really well. The other particular thing with this transplant was that we only used, as you can see in this picture, we used the uterine arteries on the lower part of the picture, but you can see the uterine veins are tied off. So we actually used the utero-ovarian portion of the ovarian veins only for the outflow. We know that this works because radical hysterectomies for cancer patients, cervical cancer patients, we actually cut out the whole cervix with the uterine veins. So we know that it's sufficient for a uterus, but it has never been proven in a transplant setting before. So there was two unique things with this pregnancy. And here is just a picture of his embryo, which actually turned out to this little boy. And we hope we can get you more and more pictures as he grows. And the update so far of our cases here at Baylor, we've done 10 cases. We have permission to do 10 more starting in September. We had the first 3 failures, as you can see, case 1, 2, 3. We then have a really good set of patients up to 4 to 7. We're all functioning grafts. 2 of those have delivered, case 4 and 5. The other 2 are in the different process of the procedure. Case 8 was a deceased donor uterus that unfortunately failed, and we think the issue there was something with the uterus, with the graft that we weren't happy with. Case 9 was a live donor uterus transplant, and it's going well. And case 10 was another live donor graft that we had to remove the day after the transplant due to factors within the uterus as well. So there's different things to learn from this procedure, but we think we have it fairly well under control now, I must say. So this is just a couple of pictures. It's always nice to show the baby pictures, and you can see both me and Giuliano with baby 1 and 2, and baby 1 and 2 together on the right-hand side, and they're adorable. So everything's kind of worth it when you have those pictures.
So one of the things that we are still working on is understanding really what is the right donor for this transplant. And honestly, we are still in this quest. We haven't really reached a consensus of what will be the perfect donor for a uterus transplant. Age may play a role, past medical history may play a role, the time from the last pregnancy to the moment of donation may play a role. I don't think we have enough science and data to come to a conclusion about that. So for the time being, as I said in the beginning, we tend to be very conservative with the acceptance of the donor. There are some pitfalls regarding the things that at least we can see that have to do, for example, with the size of the arteries and the anatomy itself, but it's very speculative. Of course, anybody can see that these arteries that are the white part over the black background and signed by the yellow arrows are good size arteries, and anybody can see that these arteries are that failed. They are much smaller caliber and probably irregular. So that plays a role. We don't know, but we do think that it might be important. As it is important to exclude this was not a donor that moved forward, it's important to exclude the one that already shows sign of calcification in the artery, meaning that they have a setup for having poor blood flow after the transplant. The thing that we really our group worked a lot. Greg DePrisco is our consultant from radiology. He has helped us tremendously to try to visualize as good as we can the anatomy prior to go to surgery in the living donors. And one challenge has been to recognize the veins. And so we have modified protocols that we try to really improve on a case basis, trying to understand how to build the best roadmap prior to going to surgery. And it's very rudimental, I have to say, because very often Liza and I have to make decisions regarding a donor based on this kind of imaging, which even to a non-expert eye show how minimalistic the anatomy and the vessels might be. And so it becomes an issue. But we learned that one of the things that we learned is how to perform the surgery itself. So this is more on a technical basis, but I think we have that really down to a very good understanding. Now, there are some positive in the story. The fact that the donor surgery for the living donor has become fairly straightforward for us is a lengthy surgery, but it's a safe surgery, and that needs to be highlighted. We had an issue or a theoretical issue, thinking whether the length of the vessel that were procured during the hysterectomy in the donor was enough for the purpose, and we had never had an issue with the length of the vessels. The recipient surgery, in terms of the setup and the way that now we perform the anastomosis, is, I think, as precise as it's supposed to be. We have been fairly lucky in terms of managing immunosuppression, so we did not have, or we have not had thus far, major issues with immunosuppression. Although, as Liza said, it's very, very important to continue to monitor this and be able to recognize potential side effects of immunosuppression. The other thing that really worked well is the monitoring for the acute cell rejection. Rejection is a word that comes always to mind when you talk about transplantation, but in reality people tend to not to know that rejection occurs in the minority of the patients, not in the majority of them. Even for us, has been a nice positive surprise the fact that we have had very few episodes of rejection, and the ones we have had were controlled very easily with normal means that we use in other organ transplants. Now, the negatives of I would describe as a question mark is the assessment of uterus quality. That's still a work in process, and still we haven't really invented or found or rediscovered a way to make sure before we transplant the uterus whether that uterus is going to be working or not. And as a matter of fact, one of the amendments to our protocol is that if we recognize that even once the uterus has been procured, that that uterus is not of good quality, we will not proceed with the transplantation. And then the one negative has been that we have had 2 episodes of iliac artery injury, thank God without long-term consequences, but those are things that we need to be very careful about because all donors and recipients are young women in their best years. I will go on quickly, if possible, with some of the ethics related to uterus transplantation. It's intriguing because the interest in this procedure started before even there was any success in performing it. And of course, when you have a problem like this, the first question that comes to mind is this something that can be discussed when it has not been performed and we don't know whether it's going to be successful. But once this becomes successful, then the ethical discourse varies on different issues. One big part of it is that transplantation has evolved. Transplantation has gone from a life-saving procedure, the one we intend for liver, kidneys, lung, heart. Life extending for kidneys is true, also true that there is a definite benefit in kidney transplantation. Life improving is, for example, if you need a pancreas transplant, you go off insulin, and so you don't have to monitor your glucose anymore. So that's definitely improving in your lifestyle. And then this BCA that was mentioned in the beginning by Dr. Johannesson is the vascular composite allograft movement that goes into face transplantation, hand transplantation, uterus, and as you heard now probably in the media, penis transplantation. The point when you have situations like this is to ask yourself, okay, this is a new procedure, what's available, and will this procedure be better than what's available to date, and what are the advantages for it? And when you think about uterus transplant, you think in terms of surrogacy. As said already, this is available in some states in the United States and not in many other countries in the world. Or one can think about adopting children, which is a different issue because adoption is one of the greatest things in our social life, but also does not allow the couple to transfer the genetic material to the children. Kaplan is a very famous ethicist in the United States, and his first approach to this was that from the Equipoise point of view, uterus didn't match. And the reason why he made that statement is that when he made that statement, there was no really live birth yet by uterus transplant. So you're not fulfilling the first premise, is that is uterus transplant successful enough to allow a family to have children? Of course, this is gone away once we have children coming from uterus transplantation. So the first question that was raised by Kaplan is now being answered. The other big ethical question is this superior to the existing opportunities like surrogacy? And that's a very broad ethical discussion because at the end of the day, the only thing, if you let aside the fact that in surrogacy in the United States, there is an exchange of money between most of the times, because there are good Samaritans that have for free, but really the real issue is that if you look in terms of risk, when we think about uterus transplantation, the person who decides, the woman who decides to have a uterus transplant and carry the pregnancy is also the one who carries all the risks for it. While when you have a surrogacy, then the surrogate mother is the one who assumes all the risk of the pregnancy and the delivery, and plus gets paid for it. So there is some ethical discussion that goes into it. The surgical risks, I would just be quick in terms of the recipient, the donor. We tell our donors that it's something in between I'm sorry, I'm running ahead of myself. The potential risk for the woman, for the recipient, are the one that, in an ethical background, you would define as is worth it, or is the ethical justified to submit somebody to surgery when the surgery is actually not needed and there are alternatives for it. And it's not one surgery, but it's 3 surgeries: the uterus transplant, the C-section, and the hysterectomy. Is that justified to put somebody under immunosuppression when there is no need in terms of life-saving organ transplantation, and knowing that there are complications like infection, hypertension, or kidney injury that are associated with immunosuppression? And of course, are there long-term risks that we haven't really identified yet for somebody who undergoes a transplant for carrying on a pregnancy? All these questions to which I ran through are very lively questions today in the ethical world. The response that we had as a center, as a group of physicians to these questions is we try to give the best possible informed consent with all the information that is available at the present time. And then we give a very strong psychological support to our women. And we do that. Anne-Marie Warren is our psychologist, is deeply involved in every single step of the way. It may seem like a justification, but really this is the way that medicine is practiced today in the United States. Is based on autonomy, so the possibility that the patient decides for himself or herself the therapy that he's about to receive, and is based on proper informed consent. And that's what we do to the utmost of our capabilities here in our center. Of course, there are benefits associated to it, and there is one thing that can also be discussed from an ethical or ethico-social point of view, and that has to do with the fact that all of us here at Baylor have been facing that probably all of us, before we got exposed to uterus transplant, totally underestimated the value and the desire of most of women to have their own pregnancy. And only when you enter in the mindset that you understand how important this procedure may become for many, many women out there. I'm going to drop this a little bit. The most important thing is that when you think about the kids, do they have any risk when they are born of a uterus transplant mother? Reality is that the only comparison we had thus far are kids that are born from mothers who are already under immunosuppression, mainly after an organ transplant, being this a liver, a kidney, or a heart or lungs. What we know is that there is an increased risk of preeclampsia, which is the condition by which there is a sudden increase in hypertension, in blood pressure, and renal failure, and generalized edema in this woman. And there is a risk of preterm labor, and there is a risk of low birth infants, so babies that are born earlier and smaller than what is supposed to be. This is the experience that we had from the organ transplant world. When you translate this to the experience that we've had in Sweden and in Dallas, we know that there is still a risk of preeclampsia, although we did not experience this here, but it was experienced in Sweden. But then when you look at the children, the babies are born for the same weight that they would have at that gestational age, and all of them are born healthy, and they are growing at the normal pace. So I think we have a very good start, at least from this point of view. And I went through this. For the donor, what we tell the donor is that the procedure is going to be in between a simple hysterectomy and a radical hysterectomy, which is performed for cancer. In between exactly there is the risk that we place. And again, this is a voluntary surgery. And so what we rely upon is proper information and proper informed consent. And the other thing that Liza mentioned is that one of the most important things is the fact that the uterus, when it's taken, is not functioning anymore. Those women do not want to have kids anymore. The uterus has been dormant probably for many years, and it doesn't really fulfill, as far as science knows today, any real function and in that specific environment. So it will fulfill a different function when it's taken away from the environment and given to somebody else. You want to finish this up?
Yeah, so I know that there might be questions too, so we're just going to finish this up fairly quickly. So as we mentioned, there was a living donor option and a cadaveric donor option, and I think in the beginning they were mostly done live donors, because in Sweden we just had live donors, and we didn't know if cadaveric donors were actually going to work or not. When we started here in Dallas, we decided to go for both cadaveric and live donors, and we had this idea that if we were starting cadaveric donors and they actually had the same success rate, that it wouldn't be ethical anymore to maybe use the living donors because of the risk of the donor surgery. Well, and the justification of the living donor would then only be in scarcity of uteri from the deceased donors. But in reality, what we've learned is that it's not so many deceased donors out there that qualify. First of all, they have to be female. They still have to be within their right age group. They still have to have their uterus. So probably, in reality, we need to have both options available. The interesting thing with cadaveric donor allocation is that you usually allocate an organ based on how the recipient is doing. So you have a score that the sickest patient gets transplanted first usually. And when it comes to uterus transplant, this is going to be impossible. No one of the recipients are more infertile than the other one or less infertile. So if more centers around the US start up, we are going to have develop new systems to reallocate organs. So the future, if we look at that, this is just a couple of things that we think is going to be important. The donors, is it going to be mostly deceased? Likely, but we're still going to rely on living donors. We're also looking into, and a lot of centers are looking into, if we can do this in another way. So far, the surgeries has been open surgeries. We're looking into if we can do at least a donor hysterectomy with a minimally invasive surgery, giving the donors a possibility to go home the same day or the day after, and not be home for work for such a long time. The major issue, though, is considering the financial issues. So who is going to pay for this, and what is the price going to be for a uterus transplant? It's a kind of an interesting area because it's an intersecting between reproductive medicine and transplant medicine, and uterus transplant, as you can see here, is in the middle. So transplant medicine is covered under some regulations in the US. Reproductive medicine is usually not, but how do we do with uterus transplant? The interesting thing with the uterus transplant, and I'm speeding a little bit now so you can ask your questions too, but is that these are females that either have a malformation from birth, and we usually correct malformations, and this is also malformation even if you can't see it, or there are females that have lost their uterus due to cancer. We usually do restorative surgery after cancer, like after breast cancer surgery. After breast cancer, why wouldn't we do it in uterus transplant? So it will be interesting to see how this will be financed and looked upon from the insurance company's point of view. Well, the challenges is, of course, as we have said already, we're taking uterus transplant now from an experimental procedure to implementing as a standard of care, and to be able to do that, we have to have good results. We have to have the financial issues sorted out for us. We also have a lot of challenges when it comes to immunosuppression and the rejection monitoring, the cost, as we said, the allocation of the organs, and defining success. The success, as we define it, is the birth of the healthy child, but what percentage, which rate do we need to find this acceptable option for women to go through? And there's also going to be another issues coming up. Of course, there's going to be single women approaching us. There's going to be transgender population approaching us. And where do we stand in that?
And then finally, the future is now, there are questions, but there are beautiful things. There are great opportunities in research, things that we will find out that can be applied not only to uterus transplantation, but also to OBGYN issues, health issues in women in general, and transplantation. There is new professional opportunities coming up for professionals interested in this field, and there are social opportunities, because we believe that we can probably stimulate the conversation regarding infertility, especially in this country, which, as you may know, is not covered for most of women, and maybe this may start a new conversation regarding how do we face and intend infertility in the United States. So I think for me and Liza, I share this, she's near me, of course. It was a deep dive in humility, understanding issues about women infertility that otherwise are really foreign to most of physicians in general and transplant physicians in particular. And it is a journey that challenges your emotional stability, because as a physician, very often we are ready to part from our patient and take care of acute issues and then probably let them go, but not with this. This is a journey that that forces even a transplant surgeon like me to be always present and understand each emotional phase of the journey. But I would say that it was worth for all of us. It was worth for definitely for Liza, for me, for the team, and for the institution. And I hope it's going to be worth for thousands of women out there. This is just very quickly our team that we really love to have around. There are transplant surgeons like Greg McKenna and Tiffany Anthony who work with us, and the OBGYN sector with Colin Kuhn, who does all the donors with us. Bob Gamby is the delivery guy. He's the one who follows this woman throughout. Mike Putman does the infertility, and Zach Rubio is the high-risk pregnancy. Christine Wallace has been instrumental, is the one with the blue scrubs and the pink stripe. She's been instrumental in taking care of all the women and recipients and donors. Anne-Marie Warren, as I said, has been the psychologist, the pillar of all of it. Greg, I mentioned already, is a skilled radiologist. James Mitchell is the one with the bow tie, and he's the one who's really paving the way for the new interpretation of the biopsy for acute rejection. And Mike Olofsson is our good friend from Sweden who's been following us all throughout. So this is our presentation, and we truly hope you have questions. We're here to listen to you.
Thank you so much, Dr. Testa and Dr. Johannesson, for such a great presentation. Before I turn it back to Haiti for questions, I'd just like to remind everyone that if you do have any questions for our presenters, please submit them using the chat feature, which is in the bottom left-hand corner of the screen. Also, during the Q&A session, I will have this poll available for those of you who are listening in a group. Please complete this poll and let us know how many people were listening in your group. At this point in time, I'd like to turn it back to Haiti to moderate the questions.
Thank you, Deanna, and wow, I'm blown away. What an incredible presentation, absolutely fascinating, and just huge respect to the work that you and your teams are doing. It's really, truly amazing work, and obviously still a lot to learn. One of the questions that has come up is what type of immunosuppression medication is being used post-transplant, and then also while they're pregnant. I mean, does that also then change what medication they're receiving or dosages, etc.?
We use a standard protocol for is similar to what we use for kidney or liver transplantation, based on the mainstay is what we call the CNI, a calcineurin inhibitor. And that's the one that we have to watch because it's extremely efficacious in the job it does, but may cause kidney issues. The good part is most of these, now all of these women are very healthy, so they can tolerate that very well. And then we add another medication that is less potent, but is extremely important in keeping things quiet, which is called azathioprine, and is not supposed to be teratogenic. Neither of the two medications I mentioned have been referred by the FDA as being really damaging to the child, to the fetus. And so that's pretty safe. We stay away from steroids are used for a very short time just after the transplant. And then the monitor, this is something that Liza touched upon, is a little bit bothersome because you have to do biopsies. There is no other way that we can really find out whether there's a rejection or not. So we have to do routine biopsies and look them under the microscope and see whether there's a rejection or not.
Routine being what's the frequency?
Well, there is a protocol that we use. We do one about 5 days after the transplant, We use that as practically a guiding biopsy, and then we do every 2 weeks up to the point of the implantation of the embryo. Then we stop because we don't want to disturb the uterus for about 3 months. We may do one during the pregnancy. If that's normal, usually we wait until the end of the pregnancy.
Mm-hmm. I recognize that we're at the top of the hour, but there are a few more questions. Dr. Johannesson, Dr. Testa, are you good to continue addressing questions just past the hour?
Yeah, we're okay.
That's fine.
Yeah.
Okay. And for those of you who have to leave us, we appreciate your participation and your time today. We will continue to ask a few more questions, but if you need to sign off, we completely understand. Have a wonderful day, and I'll continue with the questions in the queue. There has been interest expressed, and actually through the Alliance we've received an email about this before as well. How do you sign up to become a donor? What is the best way to volunteer for that?
So I think we had a lot of interest, people calling in here or mailing us, and I think on our website, in Baylor website, we have an email address. So basically, if you're interested in donating your uterus, you can just you can go into the website and just send us an email. That's probably the easiest way to go about, and then we'll contact you.
All right, great. Thank you so much. Another question was, you mentioned on one of the early deliveries that somebody's asking here, what was the creatinine GFR that caused the early delivery, and did the kidney recover?
Yeah, so that's a very good question. This is not novel to us. Even the Swedish trial, there were issues with creatinine, but it was a surprise because some of the women affected by this syndrome also have one kidney only. The one that was in our trial had 2 kidneys, but despite this, the GFR went below 50, and the creatinine rose up to 1.9. It's not a tremendous number, but if you think that it's in a young lady who's supposed to survive another 60 years after today, you become worried. And that was the only reason that brought us to deliver earlier and avoiding a second pregnancy, because we are not here to create a damage, long-standing damage to the kidney. The last portion is that, yes, the kidney is recovering. The last GFR that we measured was close to 90, so we're going back to normality, but it's an important issue.
Great, thank you. There is a comment for you as well. I'm not sure if you're familiar with the Transplant Pregnancy Registry International. They would love to hear from the recipients and the outcomes. They kind of track patients who are transplant recipients who have carried pregnancies or fathered pregnancies as transplant recipients, and they love monitoring the outcomes of those pregnancies.
Well, we are not really, for the time being, we have our own regulatory issues, but we've been very open regarding, the birth that we have had and the outcomes. So that's publicly available. And I was aware about the British one. I didn't know that in the United States as well we are keeping track of all of those, but that's good to know.
Mm-hmm. Great, thank you so much. Now, what do you see as the greatest challenge in uterus transplantation?
Financial issues.
Financial, yeah, I bet.
Yeah, it's sad to say, but it's really a very difficult position to be in, the position that Liza and I are today. We feel that we are really moving the field of infertility to a different level. We feel that we are working extremely hard to make this as routine as possible for women who do not have a uterus, but also we feel that one of the major impediments to allow many, many women to have access to this is going to be money. And that's why all the projections that Liza showed you in the beginning of the presentation are based on 1%. That's a made-up number, 1%, that comes from the simple understanding that at the amount of money we're talking today for the United States for this procedure, only 1% of the population will be able to afford it.
Another question is, what is the cold time for the uterus?
The ischemia cold time.
Mm-hmm.
Well, Liza done some studies about that. I cannot answer this question.
No, so no one, in theory, no one really knows what a uterus can withstand. So in Sweden, when we did live donors, so we had a very short period of cold ischemia. Here we had both the deceased donors and the cadaveric donors, but even the cadaveric was very local. So the ischemic time, I think the longest cold ischemic time we have here is about 4 hours.
Yeah.
The Cleveland Clinic case had a little bit longer cold ischemic time. It's hard to say after one case if that was the reason why that went not so good or not. There's been animal research in this area in saying that that's been in rodents, so it's not comparable really to humans, but it's shown that the uterus seems to be a very an organ that can endure a lot of things. So it looks like it can endure about up to 24 hours of cold ischemia without any major effects on it. But that's in animals. So no one really knows in humans yet. But I know there are several studies looking into that now.
So that kind of brings up also the question, when you reference cadaveric donation, are you referencing specifically post-brain death, or can you take post-DCD donors as well?
Wow, that's a big question. For the logistic of it, and Liza and I have developed a way of doing the procurement of the uterus, which does not at all impact the procurement of other organs. That has been developed in brain dead donors, so the one that are called heart-beating donors. For the DCDs, the donor after cardiac death, I think it all will go down to how resilient is the uterus to ischemia. And that scientific data, I don't have it, so I tend to think today I would not accept a DCD donor for a uterus today. 3 years from now, maybe I will change my answer to the question.
So final question. You touched on it briefly, but maybe could you expand a little bit on what type of psychological preparational considerations need to be made for the donor and recipient? Obviously, the donor, they're giving up their uterus, and I'm sure they've gone through the extensive testing to make sure they're ready to do that. But are there any specific considerations or concerns in terms of the psychological aspect for both sides?
Well, I mean, both the recipients and donors go through the same protocol as you would have for a kidney donation or recipient, or a liver donation and recipient. But so we derived a lot of the protocols from those areas. This is a very particular area, though, because for the donor, as we know, that the organ is not actually needed for them anymore, so it's maybe a little bit easier psychologically to give a uterus up. For the recipient, has been very strange area actually, because it's a new area and you're unsure of the outcome. So I think the psychological evaluation at the moment and so far has more been not to exclude so much, but identify the support system that is needed for that particular recipient and donor, so we can help them go through the process. But I think it's going to change, because the first group of patients we included in a trial where we had no idea how this would go. Now we have an idea how many percentage approximately that will go through with the success rate in this case. So the second group of patients we're enrolling, we can give them more information, so they will need a completely different psychological support and also evaluation afterwards.
Mm-hmm. Well, Dr. Testa and Dr. Johannesson, I know I could go on forever asking you questions, but I want to be mindful of your time and also our audience's time. Thank you so much for this incredible presentation. We truly appreciate you sharing your time and your expertise and experiences thus far, and are definitely watching to see what will continue to evolve and what you will learn from your ongoing research. Thank you so much for all that you do. Thank you to the whole audience for your participation today. And I wish everybody a wonderful rest of the day. I'll turn it back to Deanna to close us out.
Thank you, Heidi. Again, I'd like to say thank you to both Dr. Johannesson and Dr. Testa as well as Haiti for your time and such an outstanding presentation. And to all of our participants, again, thank you for your time, and I wish you a wonderful